Thank you very much. It's really an honor for me to be here. My name is David Cuccia. I'm a CEO and CTO of Modulated Imaging Incorporated. As Boston said, we're commercializing SFDI-based technologies, and our primary focus right now is prevention of chronic wounds like diabetic foot ulcers and pressure sores. It's an awesome opportunity for me to be here because I don't really get to do very many academic things in my day job. So it's fun to come back and talk about some of the fundamental science that drives what we do. But on the flip side, I might be a little bit rusty, so please give me a hard time if I skip something or something's confusing. Let's talk about it. I think I'll just dive in. Please interrupt me at any time. I think what I forgot to say is today's talk is about both spatially resolved and spatial frequency domain or Fourier domain techniques. I'm going to heavily, because of my bias, focus on the latter, but happy to talk through aspects of either. So this is thanks to Sylvain Gillot. I love this slide because, you know, over the last 50 years, maybe 60 years, much of medicine is still the same as it was. There's some amazing new technologies like the ones Intuitive is making. But in general, you know, the standard of care is doctors and nurses looking at things, poking at things. We have color photography now, but much of the diagnostics are still analog neuron-based diagnostics. There's a lot of opportunity. So yeah, the standard of care is clinical impression. It's prone to error. It has problems with disparity across skin types. Some patients who have dark skin can't be treated as well or accurately. And physicians still lack an objective means to assess tissue health non-invasively. Here's an example. This is the belly of a pig where we're simulating a problem during surgery. One of these, what's called flaps, where you've resected all but one artery and vein that's delivering and removing blood from the system. One of them has been blocked or occluded. The other one is the control. It's really hard to tell with your eyes what's going on. Immediately with SFDI or other reflectance-based technologies, you can see, you know, 10 times deeper than your eye using infrared light. You can see the contrast that's due to a lack of oxygenation. So on the bottom flap, you can tell that that one's the occluded one where it's red and black. There's very little tissue oxygen saturation, which is the fraction of blood that has oxygen bound to it at the capillary level. Very hard to measure at the capillary level with needles, impossible. And so this hopefully gives you a sense of why you'd want to develop techniques like this, because it just gives you the surgeon or the physician or the nurse, depending on the application, just more insight to help their patients better and make better clinical decisions and improve outcomes for their patients. In particular, one of the things that is driving me and my colleagues at Modulated Imaging is the prevalence of diabetic foot ulcers. You know, just kind of quickly, because we don't have time to talk about it in detail, you know, there's like in the US 30 million diabetics, and 1 in 4 of these diabetics within their lifetime will get what's called a foot ulcer. This could just be a blister or, you know, some sort of, you know, stub your toe, and because of the problem with your vasculature and your inability to deliver oxygen to the right location, it can become kind of a chronic wound that won't heal. And because they're very hard to heal, it's actually the leading cause of why people get amputations. So it might start with one toe being amputated or at the heel all the way up to the leg. It's a very serious problem. There's tons of downstream complications for the patient. And so it's really catastrophic for the patient. It's also catastrophic for the healthcare system. So there's $13 billion dollars in costs annually in the US alone that are due to this problem. And it's kind of an unaddressed problem. You know, we hear a lot about cancer, you know, all different kinds of cancer, all different foundations, all different boards, and American, you know, Medical Association focusing on that. This is kind of the Wild West, and this problem is just as big or bigger from a numbers perspective, but it doesn't have the attention or the tools that we need. You know, and this is one of many examples where, you know, many diseases start deep in tissues. Another example is a pressure ulcer where you're laying on your back or have a prominence at the bone that pushes on muscle, and then it elevates to the surface. By the time you get to the surface and you can see it, it's too late. So we'd like to develop better technologies for that. And really, this is the prime example for foot ulcers. There's been a lot of work in my field on looking at ulcers and ulcer healing and seeing if you can, identify responders and non-responders to therapies. But really, once it occurs, it's very hard to heal. We'd like to get ahead of the problem and find people that have the highest risk for forming ulcers and put them into prevention programs. In this case, programs that have been proven to have up to 85% reduction in ulceration. Or amputation rates, I'm sorry. And we're doing this because there aren't really current methods that allow us to address these patients. Visual clinical inspection, we've talked about that. It's superficial, it's qualitative. Treatment or diagnosis is dependent on skin type. Ankle brachial index is just a fancy ratio of blood pressures at the arm and the leg. Doesn't work for diabetics. Contact sensors have been developed, but you have to know where to look. Digital waveforms like ultrasound will always probably be part of medicine to understand pulse waveforms, but are never going to be a primary diagnostic that can get ahead of the problem. So operator dependent, no real ways for looking at a wide field and just saying what's there. And that's why the default is often just clinical visual inspection. An example of the power here of what can be done. This is another wound that we've created in animal models. This is the back of a rat where we've resected all blood flow vessels that could deliver flow except from this right-hand side. And with your eyes, you can see the structured light we're illuminating, but you really can't see anything else, But with SFDI or other techniques, instantly you can see beneath the surface that this area at the end of the flap, the distal end of the flap, is poorly perfused. It can't recirculate because it's too far away from a source of blood. And based on this information, we know if left alone, it will die, and that's exactly what happens. So 4 days later, that tip of the flap ends up necrosing and dying. So this is kind of the connection between measuring the tissue health and then predicting what's going to happen to it. It's a general idea, but very much central to the work I'm doing. So that's a précis for why you'd like to start, developing technologies like this. Now I'd like to take a step back and talk about the physics a little bit. Here's an anonymous volunteer whose face has been imaged at a number of wavelengths going from 400 nanometers all the way through to infrared. This is 690, 730, 850, I think. And what's interesting here is that there's a lot of complexity. We can have homogeneous models in phantoms all day, but there's a lot going on here that's both spectrally dependent and depth dependent. You can see at the top left a lot of contrast from the pigmentation and my skin, so very superficial melanin. The light is absorbed so strongly that it just doesn't penetrate more than 50 microns or so. And then as you go into the green and the orange, you get this combination of melanin plus superficial hemoglobin effects. And then as you go into the red and the infrared, you get a lot more deep tissue information. But it's not correct to say that it's just blood now. You still have melanin you have to pass through, and you still have a lot of melanin in my 5 o'clock shadow. I did shave that day, but that you can see that beneath the surface there's a lot of contrast from the hair follicles. So it would be a mistake to image a subject like this and assume a constant value for anything. It's all changing. And why is it changing? Well, we've talked about some of the things: oxy and deoxyhemoglobin, melanin, water, lipids. Those are all absorbing light. Bilirubin to some extent. Hemoglobin breakdown products if you have them, and anything else that you inject, of course, for an exogenous experiment. So you have that effect of light absorption, which is subtracting light. You illuminate, and the absorbers just remove light. But you also have tissue scattering effects. So the light doesn't go straight, like it would in a cuvette, you've got multiple scattering. You guys are all pros at that now. You know that depending on the tissue, you can have both a different scattering cross-section, different scattering anisotropy, and you can measure in reflectance or transmission mode. And scattering is beautiful because it allows us to collect information from deep within tissue. You know, especially if the absorption is low, the scattering will get you information from very deep. But on the flip side, those photons that have gone very deep, they have no idea where they came from, and there's no good way to ask that question of them experimentally. So you have to come up with approximate models that understand, you know, this diffusing of light, and at every spatial scale, you lose a little bit more information, directionality first, and then you know, relationships between mu a and mu s prime that become coupled together. So because of scattering in general, you've got this mixing of information. So when you look at, if you just looked at a photography, you know, kind of measurement, there's this much light coming back. Well, that could be have been due to subtraction of absorption or addition from scattering, and those are, you know, fundamentally related in that sense. So, you know, if you want to decouple these things, you've got to come up with some other axis to make a measurement in. Just as a point of measurement geometry, transmittance and reflectance are both relevant for all of the things we'll talk about. Primarily today, I'll focus on the reflectance. Dimensions, you know, the mu a, the absorption, and the mu s prime scattering can be done at a point or along a surface or in a volume. And primarily, we'll focus on two-dimensional mapping. At the end, we'll talk about one tweak to that, which is layer-dependent mapping, but still 2D. But 3D is definitely possible as well with spatially resolved or SFDI. So in terms of the types of light that you put into a system in order to decouple absorption and scattering, there have been many approaches over the years, and they all still have relevance depending on their problem you're trying to solve. Then the top left, let's start with spatially resolved techniques. This is where you would put a point spread function of light, a delta function, into the tissue with a laser pointer, for example, and with its, you know, beam width, let's say it's infinitely small. And then when you look at the light that's reflected from the skin or the tissue or transmitted, you see that you get a point spread function back. So you put a delta function input, but this is the cone of information that's coming back. So you can make measurements along here and determine mu a, mu s via models, via phantom calibrations, etc. On the right-hand side, we have time-resolved techniques. So you can put a point of light in time, a pulse, and then you can look as a function of time at how that pulse remits from the tissue, either transmission or reflection. Excuse me. You see there's a little bit of a delay if you have a source detector that's separated, because the light can only go so fast. And then you have this pulse function that again can be analyzed and determined optical property to determine optical properties. So this is the real domain. We put in pulses, we get out point spread functions. On the frequency domain side, you've probably heard of time-resolved frequency techniques. So instead of pulsing the light in time, let's modulate the light in time from like 50 megahertz to a gigahertz or something like that. And when you look as a function of time frequency, you see that there's a roll-off. Tissue is a low-pass filter. It's damping higher time frequency information and preserving more low-frequency information. And this roll-off is related to the inverse of the absorption relaxation time. It can be used, again, to calculate optical properties. What I'm not showing here is phase, so you can make measurements of amplitude or phase, or both, but this is the concept. And so what we did, oh, I'm sorry, so this is, these two top and bottom areas are related by Fourier transforms. So the physics of the light is the same. The light's going in and scattering and it's coming out. How you're measuring it is different, but you can take a measurement in the time domain. you can take a digital Fourier transform and get the time frequency, or vice versa. You can measure in this, you could sweep over many frequencies and do an inverse transform and get what that pulse should look like. And there's reasons to do that for instrumentation. So if you have really good time domain instrumentation for this particular application, but it's easier to process the data in the frequency domain, you can take advantage of that trick, and many often do. So we at BLI, and actually, there have been many groups that we've built our work on, have looked at the spatial frequency domain. And a lot of the original work in the spatial frequency domain was done with modeling. But here, in terms of instrumentation and measurement, we can modulate the light in space. We can change the periodicity of the pattern from a low frequency, which has a large period, to a high frequency, which has a short period. And practically, the periods I'm talking about are from zero frequency, which is planar or constant illumination, to maybe 1 per millimeter, 1 millimeter fringes. You can go higher than that, but the interesting stuff for many applications that I've worked on is kind of here, the below 0.2, 0.3 per millimeter spatial frequencies. And again, they're related by a Fourier transform. Just to delve into that a little bit more, here's the spatial point spread function. You send in a pulse, a point in space, you get a blob in space. So that's x naught, the blob is expanding, and you measure the point spread function. Underneath the surface, this is what it looks like. You send the pulse. We were looking at the surface reflectance, that's here, but under the surface, there's a lot of complex stuff going on. You can see that the source is very directional in this case, so you have kind of a pencil beam effect, and then you have more of the diffuse blob from all of that light that's radiating out. When you're trying to take advantage of this or other methods, when you've got some new axis of measurement, you have lots of questions. You have questions about sensitivity, and you have questions about separability. So we're trying to separate absorption and scattering, but first of all, we have to make sure that whatever we're doing is sensitive to these changes. If you could change the absorption a lot and nothing happens here, this is not a good approach, right? So where do you put your detectors, and how many of them should you have? So let's say we put detectors here, here, here. Well, we'll get 4 points if we have 4 detectors, and then we can fit that curve to get absorption and scattering. But let's look at the sensitivity in more detail. So if I plot diffuse reflectance, and you all have probably done this, or no, you'll do this later today, because this is a well-coordinated program. You'll see that as you move further away from your source, you'll get less and less reflectance. So it's kind of hard to show, but imagine this was a red light, not green. You'd have a small point source that then looked like a pretty big blob, and that's this is the blobbiness. If you change the absorption and scattering values, you'll get different curves, and this is going from a situation where the relationship between scattering and absorption, where they have very similar values, and this is where scattering is much higher than absorption, and you can see that they have different values. So here we're basically fixing scattering, but we're changing the absorption. So from low absorption to high absorption. Any questions? So and similarly, you can change scattering. So let's change scattering from 0.5 per millimeter, reduced scattering. This is mu s times 1 minus g. And mu a is fixed. And you can see that those curves are also changing, and maybe changing more here than here. Here it looks like we're sensitive to those changes everywhere. So absorption might be important. For scattering, it might be important to get stuff close to the source, because that's where it looks like there's a lot of contrast. But the curves are different, and because they're different, that's what gives you the intuition that maybe you can separate these effects by placing detectors at different locations. If you take that same data on a log plot, you can see a little bit more information. You can see that the absorption effect creates these fairly obvious linear effects in log space at long distances. People often use that to fit as a fitting parameter, measure the slope far away from the source. Scattering is actually very interesting in log space. You can see that here, when you have a high scattering value, you get more reflectance near the source, but less reflectance far away from the source. I mean, basically what's happening is if you have a lot of scattering near the source, then that light's going to reflect and it's going to go away. So there's not enough light, as much light to go deep and keep propagating and come out farther away. You can do tomography with this to some degree. You can place, as you place your detectors further and further away from the source, you can see that, of the photons that you've put in, the ones that are likely to be detected have likely come along these paths, which we lovingly call photon bananas, or photon mangoes in SFDI's case. It's more of more like a cantaloupe. You see that because of the different distances, they're propagating to different depths. So the light is sensing along, all of these depths, but you can see comparatively the farther distances sense relatively further depth information. So that's something that's interesting, but also you have been warned if you try to develop a probe that is trying to measure homogeneous optical properties, but you're measuring a system which might have a different absorption here versus here versus here, you can get into trouble. So small details matter, and when you're going back to your labs and developing your techniques, just think about through all of these, different things. What kind of approaches are you going to take to comparing your experimental results to your models? And is it going to be a homogeneous? Is it going to be layered? Are you trying to do tomography? How are you doing calibration? That's down here. How are you making sure that what you're measuring is just due to the sample and not due to your particular system? Localization and optical property separability. Are you going to be close to the source? Are you trying to measure deep tissue? Think about your limits of instrumentation. In that quad chart, I showed these perfect curves. In real life, you have noise, and the noise can be frequency dependent. It can be hampered by room lights. It can be all different kinds of things. Optical probes, are you going to be contacting the tissue? If you are, know that you're probably putting pressure on the system you're trying to measure and maybe flushing away blood that you're trying to measure. On the flip side, if you want to have a blood-independent measurement of skin, you probably should push on it pretty hard. Here's some examples of systems that have been developed medically that have medical device approvals to make diagnostics. Primarily around the idea of oxygen sensing, although others, and I'm sorry I don't have intuitive here, have used exogenous probes for imaging. So here's some point sensors. Hutchinson was kind of the pioneer in tissue oxygen saturation. They modeled their FDA approach after the pulse oximeter, which is looking really at kind of global arterial saturation, tells you how your heart and lungs are doing. This, instead of that, tells you how that tissue right there is doing. So that was the big leap. Vioptics followed them. Others have come along since then. Some have developed that into imaging-based systems. This is a device by Canfield. This is not a medical device. It's designed to look at your skin for complexion analysis, that kind of stuff. Used a lot by clinical research organizations when someone has a new topical cream or something that they want to test. On the medical side, Hypermed has developed a two-dimensional imaging system to measure tissue oxygen saturation. Novidac has developed a device. They've had a number of devices now, and they were just acquired. But they use fluorescence, so they inject a fluorophore, which allows you to see where the blood is. So this fluorophore is indocyanine green, and it stays where the blood is. All of these techniques and technologies have been developed with tissue optics in mind, either implicitly by figuring out sensitivity, or explicitly by using quantitative models to invert the data. So SFDI, spatial frequency domain imaging, is the technology I've worked on developing, and in many ways I see it as an extension or a translation of all of the quantitative techniques that have been developed for frequency domain, time frequency domain measurements diffuse optical spectroscopy or photon migration spectroscopy or frequency domain photon migration, all different names for the same stuff, have a source and detector, but you modulate at many frequencies. You have a calibration approach that corrects for the instrument response function at every frequency, but you're limited to point measurements. Most of these devices are contact. A few have been developed non-contact, but if you wanted to create an image, you'd have to scan that probe, and that gets really cumbersome. So we developed a way of using a spatial projector to get that information over a wide field. First we started with structured light dots and analyzing the reflectance of the little R of rho curves, and then Frederick Bevilacqua in our lab realized that you could measure these directly in the spatial frequency domain by shining sine waves in space and looking at the damping of those sine waves. I'll talk a little bit more in detail about that, but here's an example of why that might be interesting or useful. See if I can find my mouse. This is in a rat brain whose skull has been thinned, and we're simulating a migraine headache by putting in potassium chloride, and it creates a wave of cortical spreading depression. And you can see that each of these different chromophores have a different response. And if I can pause there, actually I'll pause again. Let's see. And you can see that while the hemodynamic information is interesting, you can see the blood being delivered via the large vessels and then sort of diffusing in a response to this insult we've given it and changes in oxygenation. You can also see a scattering wave that's occurring, and it's a completely different shape. It's the neurons are literally depolarizing and hyperpolarizing and then depolarizing, and we're seeing that directly with imaging. So you'd see this contrast with a point probe, but it's very interesting from an imaging perspective to see that spatially resolved. And so what's underlying SFDI is, again, tissue is a low-pass filter. Tissue is blurry, so you send in high-frequency information and it gets damped, stronger than low-frequency information. You send in the sine wave of a given frequency and it's damped with depth. Here's a curve that represents the fluence rate, the intensity of that AC wave. And then diffuse reflectance is how much light comes out at the surface, which is proportional to that fluence beneath the surface. You can see that we're illuminating with all positive light. You can't have negative photons. So you've always got to have a DC bias, so some amount of average light, and then an AC term on top of it. So there's always two frequencies in there at least, the DC and the AC. If you look versus frequency, that's the lowest frequency fluence rate curve. And then as we increase frequency, you can see two things. One is that the depth dependence looks different, and then the other is that the amplitude in itself is different. So at the surface, you've got diffuse reflectance here decreasing with frequency. That's the low-pass filter that we're talking about. And you can fit that information to a curve, in this case fit by a Monte Carlo model to calculate absorption and scattering. And so that was kind of our original work. And I'll be sure to share these slides so you guys don't have to scribble the references. But this is the spatial modulation transfer function. So this is what the transfer function looks like if you vary absorption on the left and scattering on the right, just like we did with R of rho. And you can see when you have low absorption, you have this top curve. And when you have high absorption, you have this bottom curve. And the black dots are the measurements. The red lines are the fit to a Monte Carlo-based model. And you can see the model matches the measurements very well. But what's more interesting is that it seems that only at low frequencies maybe lower than 0.1 per millimeter, 10 millimeter bands, do you see this contrast from absorption. Scattering is fixed, and absorption is the only thing that's changing, but you can see that high frequencies don't have much contrast at all. So it'd be hard to just use high frequencies to get absorption information. Similarly, or conversely, we'll vary up scattering from low scattering to high scattering. And in this case, you can see that scattering seems to have an effect at all frequencies. It's sort of a broadband effect. Because these curves are different, because the curves are different, gives you the hint that you should be able to separate the information from these. Maybe you get a high frequency and a low frequency, or you sample along the curve and then you fit, and you should be able to get the two components separated. A way to represent that information about separability is to look at these isocontour plots. So imagine you just measured at two frequencies, a low frequency, 0 per millimeter, and a high frequency, 0.5 per millimeter. So it's pretty high. And in that case, say you made a measurement of reflectance of 0.06 here and 0.55 here. Well, you could look over to this point and see that as isocontours of absorption and scattering, they're fairly orthogonal. So you know you can move in small steps, depending on the quality of your instrumentation, small steps from this contour to this contour, and know it's going to have a completely different effect than if you move from this contour to this contour. So the degree to which these are orthogonal will tell you how separable things are. And it's sort of the cross product of the sensitivity matrix. So if these are very, very flat and squished, you're going to have a very hard time separating things. So as you lower this frequency, these things become more and more squished. And that's my non-mathy way of saying minimize the partial of r squared with respect to mu a and mu s. So I'm going to try to move more quickly because what time are we finishing here, Boston? Until 10. Oh, excellent. Okay. Well, I'll keep going at the normal speed. Okay, so tissue is a low-pass filter. We've seen how it can change the diffuse reflectance as a function of frequency. I also mentioned that the shape of these curves is changing. So if you normalize those curves, you can see that the high frequencies are penetrating more superficially than the low frequencies. And so you can use this information to do some sort of tomography, with the caveat that they're all sampling all depths. So it's not a great system to try to invert. It's not like a radon transform in CT where you can pretty much tell where everything's coming from. This is an inverse. You'd have to do an inverse Laplace transform that has to be heavily regularized, but you can get depth information. And many groups have worked on this. This slide probably needs to be updated, but here are some of the earlier groups that were focusing on tomographic imaging with SFDI, both at the Beckman Laser Institute, Xavier Entis's lab, and the Kubate Dube group, Andrea Bossi's group at Politecnico di Milano. So this is just references for you, but for me there's kind of been an evolution of how people think about and use spatial frequency-based information in the literature. It comes back to Ishimaru and his work in 1978, where a lot of the modeling was done in the spatial frequency domain. Harmonic functions are a lot easier to handle when you're doing integrals often than these complicated point spread functions. So, and along the history, many times people would solve their particular math problem in the spatial frequency domain, and then the very last thing they do is take an inverse transform to get the final spatial data. So that's modeling. And then measurement in diffractive systems happened with Tony Wilson's group and Mark Neal. So they developed kind of a poor man's confocal microscope by shining sine waves of light into a diffractive system, which is basically a slide, and they used the low pass filtering aspect of a lens, a diffraction of a lens, to isolate what was happening only in the focal plane by looking at just the AC information. So they developed this technique where you just do a phase shifting sine wave, and then you demodulate with some simple math. And we adopted that. So that works well not for just diffractive systems, but any sinusoidal system where you want to measure the envelope of a function, and we applied it to diffusive systems. Nora Dognitz and Georges Vanier from EPFL, École Polytechnique in Lausanne, Switzerland, were the first to do structured light illumination and do spatial frequency domain analysis. So they did rings of illumination on phantoms, binary rings, and then they took a picture, and then they took a Fourier transform of the picture. And then what they could see is this low-pass filter information in the Fourier transform. So single picture, and then single Fourier spectrum, essentially, in a single value for absorption and scattering. And what we did was we combined these concepts and did both spatial frequency domain measurement and analysis. So instead of having to go to the Fourier domain to do anything, we do this sinusoidal illumination. We capture the AC information directly in real space, and then we can process it directly. So that's a lot of words. What's it look like? It's really easy to do. Many of you are already practicing this in your labs, which is so cool. So you have some sort of light source, probably some sort of polarizer here and another polarizer here, because we like in practical situations clinically to reject specular reflection and enhance sensitivity to the deeper photons. Some way to modulate the light spatially. So that could be a digital micromirror device. It could be a TFT screen. It could be a liquid crystalline silicon. And lately in my lab, just a simple slide. So transmission slide. And then that light is transmitted onto tissue, and it reflects diffusively. You capture that with a digital camera. And you've got to have some way of doing spectral filtering. If you want to do spectroscopy, you can either have a broadband light source on the source side and then filter one wavelength at a time on the detector, whether it's a filter wheel or a liquid crystal tunable filter. Or you could illuminate with essentially monochromatic photons one at a time serially, and that's what we do in our instrument. So with LEDs, for example. And then you can build up absorption and scattering information at multiple wavelengths, visible infrared, a mid-wave infrared, anywhere that you have some play between absorption and scattering, where it's not just one of the components that's completely dominating. This is useful. And it can be combined with many different approaches. So multispectral, we talked about. Laser speckle imaging. So one of the challenges in laser speckle and in Doppler is to know the turbidity of the sample. And you could potentially measure that with SFDI and then use that to calibrate your speckle. You could also use SFDI to do depth gating of speckle. Fluorescence, same thing. You can basically ground your measurements. If you know the absorption and scattering of the background, and then you characterize your fluorophore separately, you could do a better job at quantifying your fluorophore. You can also do a better job at localizing it. You can use it to depth section fluorescence information. And then polarimetry. Not as, probably all the same concepts apply. I'll not limit that. So how does the measurement work? We have a sine wave, again, from some arbitrary value to 0 to arbitrary value. So a unit intensity with a DC term. And what we want to do, when the tissue reflects the light, it's going to look something like this. So it's, instead of being homogeneous, it's going to be damped, and it's going to be spatially dependent. And so what we care about is really this envelope. The thickness of this envelope is the AC information, and it can be decoupled from the DC information by phase shifting. So we take 3 pictures. This is one way to do it. There's many ways. And you can get then 3 values at every pixel. You can apply some simple algebra math where you subtract each image from itself, from the other one, you square it, you add them, and you take a square root. It's just a quadrature combination. And then you get this envelope. You get this measurement of the envelope function. To this day, this seems to still be the easiest way to do things. There are other ways where you can just have a single sine wave, and you can do Fourier-based techniques to look at the envelope. Those have some challenges with localization. So the resolution in space that you can get might be lower than you can get with a 3-phase technique. That's just one other way to do it. And here's what it looks like in pictures. So you have maybe a planar light that's DC, and then you have maybe 1 or more frequencies of AC. You combine these AC device measurements through demodulation, and then you calibrate both of those to flat field. And then you use that information of low and high frequency to calculate absorption and scattering. If you do that versus wavelength, you can calculate things like tissue oxygen saturation. Boston.
So if you can go back to your previous slide, David.
Yeah.
So as you're showing in these plots, you're really focusing on this envelope function of the demodulation, kind of analogous to temporal frequency domain imaging, where they often acquire both amplitude and phase. Are there any phase techniques, or is there any valuable information embedded in the phase of this signal?
Thank you. And yes. Yeah, so I'm just talking about amplitude here, but there's one particular reason I don't show amplitude phase information here, and that's that the phase is roughly constant. We're illuminating straight down and imaging straight up. So the phase of the incident wave and the reflected wave are the same. But if you come at an angle, that wave is going to shift. It's going to hit the surface, and then it's going to keep on scattering, just like the point beam scatters, directly down or at an angle. This will also do the same thing. And so the cumulative phase of the reflected wave will be sort of the integral of all, the way that wave is interacting at all the different depths. So in the case that you had angled illumination, you could change the angle, or you could look at frequency dependent at a given angle, and particularly in tomography, it hasn't really been used yet experimentally, but I really think that could help do near field tomography with SFDI.
What particular information do you think might be encoded in the phase, or what might the phase be sensitive to that the demodulation may be less sensitive to?
Well, the thing that comes to mind immediately is just that if you're doing imaging and trying to do tomography, each object at each different depth will sense a different phase. And when you look at the inverse problem in the Fourier domain, it's kind of there's a uniqueness problem when you try to invert where you have no phase information. And if you're trying to do an inversion in the near field, if you had that, you'd probably have less multi-valuedness to your problem.
Okay. I think we have another question.
So in practice, how big would that angle need to be in order to see different phase information? And also, how much of an angle in your illumination would be a problem if you're only trying to look at magnitude? Would that start to interfere just in geometry concerns and setting up your imaging?
Yeah, good question, thank you. I think geometry, you hit on it, is the biggest problem. We often pretend that these are semi-infinite or flat samples. When you have curvature, you immediately have an instrumentation challenge or a measurement challenge, because there's phase shift just due to the height and angle of the surface, let alone what's beneath the surface. And if you have a height change, basically, this wave that's coming at an angle will go, shift in phase longer to go to lower heights than closer heights. So that's number one. You've got to figure out what the phase of your surface is, and if it's not flat, you've got to have that known very well. And there's ways to measure it. You could use, non-polarized, non-cross-polarized light or high absorbed light, like blue light, to get that phase of that initial surface. And then the phase shift you're looking for because of the SFDI is going to be kind of riding on top of that, and it's going to actually be much smaller. In terms of what angles, it depends on the optical properties. I think the lower the scattering, the smaller the angles you'd need to see an issue or some contrast. But 10, 20, 30, 40 degrees are all very doable experimentally. There's a technique called lens shift, where you might have seen it in photography, where someone's trying to take a picture of a large building, and in normal pictures, the image is skewed of the building. What they'll do is lens shift photography, where they get an extra large format lens, and then they'll just literally vertically shift it with respect to the CCD camera, and it sees much less parallax distortion. You can do the same thing with projectors, because it's just the opposite of a camera. So you can put the pattern here, the lens offset, and you can shift and project the image without any distortion of the sine waves. That keeps the same spatial frequency across your field, even if it's at an angle. Thanks. Yeah. Sorry.
So even if the light is not coming at an angle, if there's a curvature in the sample, there would be some different estimation of the light, right, due to the curvature. It could be.
I'm sorry. What's
So
that?
if the sample is curved,
Curved.
yeah, so there could be a different estimation of the light coming in, right?
Yes.
So do we do some kind of an angle correction for that?
Yes.
Right.
Yes, so that's right. Not only will the phase of the wave be different, but the amplitude will be different. Whenever you look at someone's face, the sides of their nose are dark, and it has nothing to do with having more absorption. It's just because it's at an angle. So your eye is the detector, and you're seeing kind of a cosine of the information that's coming back, which is Lambertian typically, which is fairly distributed. And so there's various things you can do. I think I do have a reference to what we've done. We worked with Sylvain Giroux and his lab first at Beth Israel Deaconess Medical Center, and now he's in Strasbourg, France, and we developed a way to use phantoms to measure multiple phantoms at multiple heights. And so we get the amplitude as a function of height. And then we've developed an analytic expression for what we expect the reflectance to be as a function of angle. And then we use the profilometry to measure the surface curvature. And so then as a function of both height and angle, we have a calibration matrix essentially that allows us to look up the correction factor that we need.
Okay, thank you.
I was just curious about the fact that you're varying the frequency in one direction. I was wondering how that affected the resolution in other directions.
That's a good question. Yeah, so when you think about optical imaging and resolution, you immediately think about both vertical, horizontal and vertical spatial frequencies. And there's a little bit of decoupling of that importance in diffuse light imaging, because what we're trying to do is capture the response of an object beneath the surface or a medium beneath the surface, which has, most of the time, has scattering that's fairly isotropic. So of the photons you detect, especially if you're using infrared light, you can expect that most of those photons has been completely randomized in each direction. So no matter if you shine sine waves in this direction or this one, you get the same damping at that same spatial frequency. But it's a good question, and it's been an area of investigation. So on the flip side, you might expect that organized tissue that had, it could be collagen or it could be bone, had some structure that was, preferential along one axis. For example, imagine I have bone fibers running, vertically or down my arm. If I measure even with a point source across my bone versus along my bone, you'd imagine maybe there's more channeling and less scattering along this direction than this one. And that same physics could be sampled with SFDI. So Soren Konecki and Tyler Rice have worked at Beckman to rotate patterns, and what you see is maxima and minima of scattering cross-section, and you can relate that anisotropy to the tissue type. So just the anisotropy, Bruce Stromberg likes to call it a diffusion tensor, that you'd sample that difference with that information. But in terms of imaging performance, we found practically that you really only need one direction.
Approximately how long does it take to acquire an image with this technique, and is this something that could potentially be incorporated into an endoscope?
Fairly quickly, and yes. So there have been techniques that allow you to do imaging-based stuff with just a single fringe projection, with the caveats of maybe lower spatial resolution and maybe scene-dependent reflection. But in that case, if that's kind of the extreme, it's just as fast as you can grab an imaging frame. So that could be a millisecond. It really doesn't have to be much faster, slower than that. You have to, camera readout times are the same for any other reflection-based technique. For us, we take 3 pictures. Let's say, well, let me summarize. For our skin-based measurement, which I'll tell you about in a second, we take 5 planar light reflection measurements and 3 spatial frequency measurements. So we take 8 pictures and 1 dark. And between those 8 pictures and 1 dark, we have all the information we need to get melanin, blood, scattering, tissue oxygenation. So less than a second in that case.
Okay.
Yeah. And definitely reasonable for continuous monitoring. Connie.
So you said 5 planar illumination and then 3 spatial frequencies. Is that 1 spatial frequency, 3 different phases, or 3 different frequencies?
Yeah, thank you.
And is
I
that,
misspoke. It's 3 phases of.
I'm
one
not even
frequency.
sure what you said. So it's 3 phases of 1 frequency,
Yeah.
and is that only at 1 wavelength, or is that broadband?
Yeah, so for us, we're doing it at 1 wavelength, 1 or 2
Okay.
wavelengths for the SFD.
And the 5 planar illumination is different wavelengths, or all the same?
Yes, yeah.
Okay.
So blue, green, red, and 2 infrared.
Okay. Interesting.
I'm just, could you explain how you get your lateral resolution and axis? I'm a little bit confused because if you have a spatial frequency, don't you need to, you're essentially deconvolving over that entire x distance, right? So how are you able to, in your images, get those multiple pixels in x?
That's a good question. So I think maybe this is the best slide to talk to that. So there's 2 different scales. One is the pixel resolution of the camera, and you can see I have maybe a megapixel of information here. So at every spatial point, I can sense this wave that I'm illuminating with, and I've picked the frequency of this wave to give me good separability between absorption and scattering contrast at that spatial location. I'm not claiming that we have 50 micron pixel resolution, inherent resolution. I would say probably it's 4 or 5 times that, because of the blurring of the light. But there's a decoupling between the spatial resolution of the reflected, this is the diffuse reflectance that's calibrated, this is the absorption and scattering that are calculated, but they're all done at this point-wise location where we have this planar assumption, so that we assume that the optical properties are varying slowly compared to the diffusion of the light. And so we get relatively high resolution photos of absorption and scattering, where we're still using very low spatial frequencies to do the decoupling of absorption and scattering.
So if we are not doing tomography and all we want to do is separate absorption and scattering, do we need just 2 spatial frequencies?
It depends. Good question. So you would need to know that you could treat your tissue as homogeneous. And in that case, yes. And I think I have a slide on that. Let me see if I can jump there and jump back. Well, actually, I'll use the slide we already talked to, which is the separability. Sorry. This is a lot slower than I expected. There we go. So what we showed was really you just need 2 frequencies to get very separable orthogonal information. It's very easy with the spatial frequency domain compared to others to use just 2 measurements to decouple. But that is in the case that you have a homogeneous sample. If you have like melanin near the surface that's strongly absorbing or variably absorbing across your patients, then it might not be good enough, depending on what the metric you're looking for. And that's what we found for our skin measurements, is that we've needed to have a multi-layer model to accommodate for that difference. So yes, only 2 frequencies for homogeneous, but not a ton of frequencies for non-homogeneous. And the trick we've taken in our work is actually not to add more frequencies, but to add more wavelengths. So we can constrain the problem a little bit more with some spectral information and still use the, a single spatial frequency or maybe two frequencies to decouple this, this interaction between absorption and scattering.
Okay. And also for the high frequency cases, the light is not really penetrating much into the tissue, right? So if we go to frequencies as high as like 1 millimeter inverse, we wouldn't get a lot of depth information.
That's right. Well, you'd get very clear superficial reflectance information.
So it depends on the application again.
Totally depends on the application.
Okay.
There's a surgery application right there that if all you did was collect high spatial frequency light, you can get images of skin or the surgical bed that are much higher resolution and contrast than you can see with your naked eye. Your eye sees planar light, which is going deeper. And so, it could be very useful for looking at tumor margins, for example, if you just looked at high spatial frequency light. You'd be challenged to extract absorption information out of that superficial information, but the scattering information is there. And Dr. Chad Kannick and the Brian Pogues groups have looked more extensively at high frequency light and how they can not just see scattering contrast, but see differences in anisotropy and what they call the gamma parameter, which is another next order description of how light is scattering, and found that to be very diagnostic.
Okay, great. Thank you.
All right. That was fun. Stand by. I should probably just go to slide sorter mode, huh? Okay, so this is just a conceptual slide. I drew this with PowerPoint, but you can see that the absorption in tissue is spectrally varying. And essentially, if you want to do spectroscopy of blood, you've got to make measurements at more than one wavelength. So if you make SFDI measurements at more than one wavelength, you can measure reflectance, but then get both of these curves. You can get measurements of absorption versus wavelength, and use that to fit for chromophore absorption based on their known absorption spectra. If you don't know what you're looking at, you can use chemometric techniques to decouple different spectral features. On the scattering side, you can use both this cross-section and the wavelength dependence of the scattering signal to have diagnostic information as well, and that'll tell you about the density and size of the scatterers. So we were talking a little bit about profilometry before. So this is the validation work we did with Sylvain Gieux, where we measured at multiple heights. We tilted phantoms in both directions. We showed that we could measure height and compared to theoretical get very good results through this profilometry measurement. I think I forgot to say it, but when we're talking about profilometry, so we talked about amplitude and phase and how phase from the tissue is interesting, but phase from the surface is also interesting. You can measure the phase, and that will give the bulk phase, not the subtle effect of tissue, but the bulk phase will tell you about the height of the tissue. So you can use that information to calibrate your results. Okay, so calibration is a huge topic. We've created these tools that you've started to use in the virtual photonics simulators, and one of the big things that's kind of not addressed with those tools is the fact that in real life you've got real world systems with noise, with spatial dependence, with time dependence. You have the MTF modulation transfer function of your system, and you've got to come up with some way of correcting for it, or knowing what it is, or comparing your measurements to other standards, like you can have arrays of phantoms. You've got to figure out ways to make sure that if you're fitting reflectance, that it actually is reflectance. Reflectance should be a kind of a unitless number from 0 to 1 that is telling you in an absolute sense, if I send in 1 unit of light, or a billion photons, how many of those billion will reflect as a fraction. So the point spread function, or the MTF modulation transfer function of the optics, is important. Inhomogeneities of your illumination, spectral dependence of all of your filters in your camera, and your sources, the temporal response, all of these things need to be calibrated somehow or addressed or thought through. And so that's kind of just a placeholder for you to think about your own stuff, because it could go in any different direction. In the spatial frequency domain, what I really like about calibration is that every frequency can be independently calibrated through division as opposed to deconvolution. So when you have a system in the frequency domain, as long as it's a linear system, meaning you double the amount of light that goes in, you get double the amount that comes back, if you can characterize your MTF, you can basically divide it out. Your measurement consists of the initial the intensity of the light times the MTF times the diffuse reflectance. Those are the three things inherently that are happening when you make a reflectance measurement. And so if you measure this same MAC on both your target and also a sample or calibration device, then if you take a ratio of the two, you can basically correct and remove this term, because I naught and MTF are both the same for both systems. And so what you get back is a ratio of the diffuse reflectance of your target or your tissue to the diffuse reflectance of the phantom. And then the last step is to know what the phantom optical properties are. That's its own lecture. But if you do have the ability to predict what the reflectance of the phantom is, then you can correct for that term too. And you can isolate your diffuse reflectance. Okay, so taking another jump, this is just kind of a report of what we've been doing, and it may or may not be interesting to you, but we as a company started when I finished graduate school. We got a SBIR, Small Business Innovative Research grant funded to kind of take the next steps to commercialization of this technology. So the company was awarded the grant, but it's very much like an academic grant, and then it's research-based, so you've got specific aims and all the same stuff. And so our aim was to go from something that was thrown together in a lab, every night it changed depending on what we were doing, to something that maybe we could hand to a nurse, and they could go into a hospital and make a measurement, and we would trust the data that came back, and we would know how to analyze it, and it would be the same all the time. So over the years, we were successful in raising multiple grants to develop the technology. Still using a lot of off-the-shelf parts in this device. In terms of the benefit to the company, our main challenge was to learn about the market opportunities and see where we could really make an impact in medicine. It really wasn't to get all of the cost out of the system. This is 2014. We have now a medical device that's 510K cleared based on this CART systems. I know in a number of your labs, in O'Sullivan's lab and in Robler's lab, and Dartmouth, there's, for Dartmouth it's coming, there's going to be one of these CART systems soon as a research device, and each of our research customers use it for something different. From Estee Lauder, that uses it to study skin reflectance. They've measured almost 1,000 patients now, and understanding how does collagen and skin age affect appearance, and what happens when you put different creams on, etc. To people looking at chemotherapy effects, angiogenesis, and response to chemo regimens, and everything in between. So that's a research device that kind of turned into a medical device by us locking down the software and addressing specific claims that we'd like to claim. And the claim that we have is that our medical product, Oximeter CS, determines oxygenation levels in superficial tissues for patients with circulatory compromise. This is a very generic claim, but it was matched to our predicate, which was matched to the Hutchinson. And over time, we hope to expand the claims that we can make medically. Predicate was HyperMed OxyView, so that one of the imaging systems I put up there. They also had a map of tissue oxygen using visible light, so not nearly as deeply penetrating. Here's a video of practice how the device is operated. It's a touchscreen tablet, it's a Microsoft Surface tablet actually. Some structured light, some planar illumination, and in about 10 seconds it's processed, and you can do investigation of the data in regions of interest. and it collects information about tissue oxygen saturation here. So you see it's 88 within that 50 pixel region he just touched. Oxyhemoglobin and deoxyhemoglobin values, and then color photograph to compare. Our competition is doctors and nurses looking and poking at things. So we always have color photography built in. So to develop that system, it took many years, both from the algorithm development, but also just understanding sensitivity and, what's kind of the minimum thing we need to do in order to make sure we're confident in the results that we're getting back. So, for example, how many spatial frequencies do you need? In our JBO paper, we showed that if you use 30 frequencies or 2 frequencies, as long as the system is homogeneous, you can recover mu A and mu S prime over many orders of magnitude fairly accurately. And there's some variation here, but you'll find that it's actually just due to sampling error. That if you collect more and more images and you average, you can get roughly the same information. How many wavelengths might you need? And these questions, are not answered definitively. These are just for us. What did we need to move forward? Mon Mazar did some work that was based on Alper Korlo's work at UPenn, and it was essentially doing what he called kappa analysis, looking at the goodness of fit of the inverse problem when you're using, 2 different wavelengths, and finding a minimum in the kappa showed that to just calculate oxy and deoxyhemoglobin well, it'd be really good to have like a 730 or 720 nanometer wavelength, and maybe something like 850, 860, 870. So that's ended up being, helping our wavelength choice for our system. Assumptions of modeling. So, you can have a standard diffusion approximation estimate that works locally well in some cases, but then over a larger range of optical properties, it might not work as well. And so various groups, including Alvin Kinlay's group, have looked at the errors that you'd see in different assumptions of models, including, which was why I put this up here, and I think it's interesting, all different phase functions. So when you use different phase functions for the scattering of light, what's the result in terms of the change in reflectance at different spatial frequencies? Now, I will say that once calibrated, some of these things tend to disappear, but there's still contrast there, and that's real. So the further away from your reference that you get, the more this will be a problem. Effects of tissue curvature. So when you change the height and angle, what's the resulting sensitivity to error in scattering and absorption? And you can see it's quite high. So making sure to correct for the height is important, and that's what we do. You can see how these waves are bending around that hemispherical phantom. And so if you do without correction or with correction, you see that you can improve the results quite dramatically. There's still more work to be done here, and I know the Robler lab has worked hard on that.
So just a question right here with that hemispherical phantom,
Yes.
as you kind of alluded to before, you may have flat or flat-ish tissue on top, but then structure underneath, like, looking at, say, bones in the hand. Do you find similar issues with error when you have offset angles that are underneath your initial incident area on the tissue, or does it not change things as much once you have a flat surface on top?
Thanks for your question. We honestly haven't looked at that directly. My mind immediately goes to anything that's beneath the surface is sensing the diffuse light, and so it becomes more of a tomography problem where you would need, if for example, the bone, you might assume that you have a homogeneous distribution except for inhomogeneities that could be modeled, where you kind of have a Green's function of what that bone would do to the field that you observe at the surface, and then you would invert that to localize the bone. I think of it more as localization at that point, but it would be a thing, and it's just that the diffuse light tends to make your intuition about free space optics not usually apply. Okay. Calibration, I mentioned that you can have a series of phantoms. So if you put different amounts of absorption and scattering in phantoms like this, and you had a big grid, you could just make measurements of each of those, and then you can make measurements on tissue and just do direct comparison. So that is a method of calibration, right? It's empirical calibration. It leaves a little bit to be desired when you go multispectral, but it is another approach. But typically, what we do is instead we try to know the optical properties of the phantom, and it's not an easy problem to know what the phantom optical properties are once they cure. Most often, it's important just to be consistent. So if you calibrate everything over time to the same phantom, and that phantom isn't changing, then even if you have some small bias, you can compare your results, and you don't go crazy. There are many methods to choose from for characterizing the phantoms directly. So you could characterize with inverse adding doubling in a small sample, and then you could use that in your spatial frequency domain, for example. There's all different kinds of ways to do it. Just one point on other embodiments of spatial frequency domain methods. If you give up imaging inherently with a camera and said, I just need a 1-pixel camera, I don't really care about doing spatially resolved stuff, that pixel could be actually a lens, a fiber pixel. And that fiber optic could be delivered to a spectrophotometer. And that spectrophotometer could get sub-nanometer spectral resolution of this spatial frequency domain stuff. So it's an important thing to remember that SFDI, I stands for imaging, but SFD, spatial frequency domain, is just this way of changing the phase or sampling the envelope function, and that sampling can happen only at 1 pixel. That's what every pixel is doing in the camera, right? It's independent from the next one for most things. So if you trade off spatial and you just have one spatial point, you can get very good spectral information, and that's what we call SFD spectroscopy, whereas a leveling called by Dr. Rolf Sager SMOCS, spatially modulated quantitative spectroscopy. Native spatial frequency domain detectors, so you can have 2 DMDs. So say you project a spatial pattern onto the object, say it's a sine wave. You could also then collect that through optics onto a spatial light modulator that had a sine wave shape. And then by looking at just the integral value of the light that goes through that filter, you can sense the amplitude of that sine wave. And so a group in Montreal has done that. That's Professor Lesage and Xavier Intes. Xavier Intes has now taken this concept and done many beautiful things with it to do very high time resolution techniques. So they have a time resolved SFDI system where they're collecting tons and tons of information, all with just a single photomultiplier tube. And you can even build up images in this manner. It's sort of a compressed sensing application for SFDI. Finally, some validation that we've done. Just quickly, you can add yeast to blood, or you can add potassium dithionite to blood that, irreversibly, in the case of yeast, the yeast eat the oxygen, so you go all from oxy to all deoxy, or it's a potassium dithionite irreversibly binds hemoglobin and sets a specific oxygenation. And so you can validate that your measurements, in our case SFDI, of tissue oxygen saturation correlate to the PO2 measured by an oxygen electrode in the sample in this curve, and this is the Hill dissociation curve. It's well known in medicine. So that's one kind of validation you can do. Another is to, again, block blood flow into or out of a flap. This is the very first data image I showed. This is invasively. You can see there's a Doppler flow probe here and a balloon that allows us to block the blood flow or open it up. And this is what happens when you occlude and then release, and occlude more and release and occlude even more. and release. So this is over the course of 4 hours. And so we use this to validate the sensitivity of our device to these changes and to show differences between arterial and venous occlusion dynamics. We also used it to show that when SFDI can see changes earlier than you can with your eye. You can see that this bottom flap is very hard to tell. Maybe that last picture, it's a little more white, engorged vessels too. But very early on, you can see contrast from the diffuse optics. We validated by comparing to other technologies, point probes, NIRS probes. So here's a NIRS or DOS device where we're doing hemorrhage in an animal. This is part of a military photomedicine program. And then resuscitation, where we give them their blood back, autologous resuscitation. And modulated imaging or SFDI showed very similar trends. It's very early data. In that same project, we looked at hemorrhage over in 4 different pigs. And compared that to mean arterial pressure and saw good correlations. This is kind of a shock application, so whether it's a troop on the battlefield or it's someone in the critical care unit, some sort of non-invasive monitoring to see early warning signs for shock. Could even be in the neonatal ward. Validation in the burn application. We've showed that it's the scattering contrast that is actually most predictive of burn injury compared to oxygenation. There's many other great things to do with polarization, et cetera. But for us, we were able to make a measurement of tissue scattering immediately after a measurement, after an insult of a burn wound that was directly predictive of outcome. We validated the burn depth of the wound by Menton staining to the burn depth as estimated by SFDI. Spent a lot of time on quantitative modeling of skin. So this aspect of the fact that not everything's homogeneous, and sometimes it's homogeneous enough that you can kind of stick your fingers in your ears. And in other cases like us, and melanin correction was not good enough. We needed a multispectral model that had multiple layers. We could accommodate for superficial melanin right on the surface, hemoglobin that was in the top 1.5 millimeters versus hemoglobin that was deeper than that. So now our newest algorithms calculate all 3 of those layers independently. And that's actually been really relevant. The superficial and the deeper hemoglobin have very different signals for diabetes, and the ratio between them is very diagnostic for risk for ulceration. So in our real data system, we have multiple wavelengths and spatial frequencies. These are the raw images, then we calibrate it, and then we put it through a wavelength and spatial frequency dependent model to calculate chromophore maps. Yes.
So how do you calibrate that for the different purposes you've talked about with monitoring burn depth or diabetic foot ulcers? Because you've much thicker skin layers in one part of the body versus another.
That's a good question. So our scattering estimate is a homogeneous estimate, and that's the number one thing that sets the spatial scale for light transport. So as long as we're in our model saying that the scattering can be different, and we're able to calculate it, then all of the other stuff kind of calibrates to the right level, if you will. I mean, it's a very non-quantitative way to say it, but if you're not correcting for scattering, you can get all different kinds of reflectivity from all different thicknesses of skin, from really thin skin on an older person to a really thick, foot pad. But if you're measuring the scattering, then you know what that spatial scale of light transport is. You know roughly what the depth penetration of the light is, and then the absorption effects kind of layer on top of that. So in practice, we have lookup tables where we vary scattering and we vary the concentrations of blood and other chromophores in each layer. And we have these giant, lookup tables where, scattering is essential for us to be centered where we can do the spectroscopy.
Okay, thanks.
Sure.
David, did I understand you correctly? So you're assuming 3 different scattering values for each of those 3 layers?
No. Sorry. So we, in this case, just have a homogeneous estimate for scattering, and then it's the chromophores that are layer dependent.
Okay. So you're assuming homogeneous with respect to scattering.
Yeah. But still, by quantifying scattering, it gives us that length scale.
Got it. Thank you.
Yeah, average path length, if you will. We're almost done. So here's an example of a validation experiment you can do where you occlude your arm and you look distally. The oxygenation should change, but the melanin shouldn't. These are ways that we validate our models. So we're very happy with this approach, and we've done validation for our FDA in 18 subjects where we occluded the arm of multiple subjects, showed a dip and then an overshoot, kind of classic response you'd expect, compared that to our predicate, compared it to literature, showed in a box and whiskers plot that occluded versus baseline for across all volunteers in skin types 1 through 6 all had statistically significant differences, giving credence to our claim that we measure oxygenation in tissues, superficial tissues for patients with circulatory compromise. That was the circulatory compromise. It's sort of accepted as it's not a gold standard, but it's the best we can do. Here's another way you could validate it. Compare on left SFDI in blue dots to TCPO2. So that's the oxygen that's breathing out of the skin measured by a voltage. And slightly different dynamics. The oxygen is in different compartments, but all due to the same cuff occlusion insult. And you can see that they both show the same statistically significant results and similar dynamics. Final point that these are small changes. Here in green is baseline and red is occluded. And you can see in the low frequency, which is this higher reflectance here, that's the DC reflectance versus wavelength, that there's a small change, maybe 5-10% change here, much less here. You can see the change in the AC curve is almost nothing. So we're changing hemoglobin, we're not changing scattering, and so you wouldn't expect it to change, and it doesn't, so that's good. Here's one, clinical applications could be giving feedback to therapies. Here's an example at the Beckman Laser Institute where a patient is getting treatment for their port wine stain, where every patient has slightly different skin pigment, slightly different vasculature and depth of vasculature. So the concept of being able to measure a patient and tune parameters to optimize treatment and to follow the efficacy of treatment over longer periods of time. Here's an application we're pursuing at the company. I mentioned the different blood layers have different physiological information. So the superficial blood tells us about capillary perfusion, which you want a lot of, and if you don't have it, it's bad. On the flip side, the deeper blood tells us about engorged and pooling of large vessels. And if you have a lot of blood deep in tissue that's not recirculating, that's bad. So the ratio of those two turns out to be diagnostic. And we've shown the ability to differentiate different clinical risks subjectively with the SFDI ratio. And that's what we're pursuing commercially. Finally, I almost took the slide out. I've had it in there for years. Something that's very interesting to me and hopefully to one of or more of you is the relationship between microscopic optical properties and macroscopic ones. SFDI is a neat tool because it allows you to somewhat, cross that range of micro to macro by going from lower to higher spatial frequencies. And comparing to confocal microscopy or multiphoton microscopy, you can start to look in more detail about the spatial features, the spectral features of skin at high resolution, and compare that to what you observe, mesoscopically or macroscopically. And so you may have some new insight that you gain from microscopy, but might not be practical to bring to the clinic. But if you can develop a sensing method that gets to the parameter that you care about, then maybe you can translate that by doing these combined types of studies. So thanks to everyone at BLI that mentored me and participated with me in some of this validation work, and to the funding we've received. Thanks to Virtual Photonics for allowing me to participate and for allowing me to be part of the initiative. And thanks to everyone at my company for everything you do. So.